I'm very happy to introduce one of my colleagues, Lindsay Palomino. She's our apheresis nurse manager at the SCCA. Lindsay has been a nurse for over 20 years in the fields of oncology, bone marrow transplant, and apheresis. She has over 18 years of clinical apheresis experience, including 4 years in the medical device industry providing customer technical support and training. She has built an FDA FACT-compliant apheresis program, implemented a healthy donor cell collection facility, authored 4 abstracts, developed a training and competency program, and implemented a pediatric photopheresis program. Lindsay is currently the nurse manager of a 6-bed, 16-nurse apheresis unit at the Seattle Cancer Care Alliance and is a subject matter consultant. And she loves peanut butter and marshmallows, so make sure you ask her about those things. Thank you.
Hi, everyone. So there's a couple of truisms that everyone should pay attention to in life, and one is don't wear white before Memorial Day, and the other is don't ever follow Fred Applebaum in a conference. So I'm going to dumb this down a little bit, just make it a little bit better. Where are we here? So disclosures, I haven't had any peanut butter today, so this could go a little bad. And I also am a nurse consultant for Juno Therapeutics, and I'm also married to somebody who works for Juno Therapeutics, so the breakfast and dinner conversations are not very light in content. There's a lot of business talk. So I'm here to talk about operational aspects of apheresis, and I think it's important for us to all kind of remember that the raw material for immunotherapy starts with apheresis. So I'm going to be very much about apheresis focus for this conference, for this presentation right here, but understanding that we're just one little piece of the pie. But I'm going to be very egocentric for the moment when we're doing this conversation here. So operational aspects of apheresis are many, even not related to immunotherapy. And I have to say that without a huge team of people, we would not be able to pull off these apheresis collections that we're doing, certainly for immunotherapy, but otherwise. And I'm looking right here at Jeff Ratiana, who's keeping me on the straight and narrow most of the time. Thanks so much for that. So these are just a few of the aspects that we have to pay attention to, and I'm going to cover all these in this talk today. As I mentioned, apheresis, this is where it starts for immunotherapy manufacturing. And leukapheresis, which is the term for white blood cell collection via apheresis, is where it starts. That's the raw material for manufacturing, and that's regardless of what the manufacturing method is. So whether your product is a clinical trial in development, if it's a commercial product for Argos or for Bluebird or for Juno or for Celgene, it all starts with that raw material of white blood cells that are collected via apheresis. And the process of collecting white blood cells via apheresis has not changed significantly over time, despite modernization of the collection instruments, which are now more user-friendly. They're prettier, they have nicer bells and whistles, and they're safer for the patients. But just like putting your pants on, there's just not that very many ways to get white blood cells out of your circulating peripheral bloodstream. So attention should certainly be given to how these cells are being collected for immunotherapy products. And we should also be paying attention to ways to optimize these cell collections for these immunotherapy products. But manufacturers need to also be very understanding of the limitations of apheresis. So a little bit of background, apheresis 101, for those of you who aren't very familiar with it. A for what is usually how we hear it from the public. Blood is collected from your bloodstream using an apheresis instrument, which is not a dialysis instrument. Dialysis filters, apheresis separates. So whole blood is removed from the circulating bloodstream. That whole blood passes through the apheresis instrument, which separates out that whole blood into its components of liquids and solids, which is plasma and cells. And it uses a centrifuge to do that separation, isolates the targeted cell, and returns everything that's not targeted or unwanted for the therapy back to the patient. This is a simplistic rendering of what apheresis is, and it's a little bit more complicated than that. So here is a photo and a diagram of kind of the finer details of apheresis. In this photo on the left, this is the view looking into a portal, a viewport of an apheresis instrument, and it's showing the cell separation that's occurring. So that deep red layer on the bottom, that's red cells that are separating out. On top of that is a very impossible to see white blood cell layer, and on top of that is plasma. So broken out in an animation here, you can see that plasma is the lightest component. It's liquid, it floats on top. Underneath that, the white blood cell layer with platelets floating right on top of that, and beneath that, the heavy red blood cells. But to say that the cells are separating out in layers is not quite accurate. They are separating out in layers, but not very distinct layers. So when you see this, there's always going to be overlap with plasma and white blood cells, and overlap with white blood cells and red blood cells. And that's because apheresis separates cells by specific gravity. And you can see here that these cells don't have significantly different specific gravity. They're different enough that the instrument knows how to layer them out differently based upon their weight. But you can see that red blood cells, while they're heavier, they're not significantly heavier than everything else. So what you can run into is that young red blood cells that have just been born a few weeks ago, a day ago, they may be the same weight class as the heavier of the white blood cells. So granulocytes might be mixing in with the red blood cells. And then also on the upper reaches of the buffy coat, which is so termed because it looks buff color when you separate out that layer, the platelets are floating on top of the white blood cells, and those platelets will be mixing in with the lighter of the white blood cells. So if somebody's saying, I'd like you to get T cells, those are going to be somewhere in this layer of lymphocytes and monocytes there, but they may be getting some other cells along for the ride. So this shows you a little bit more detail about that. Now remember, that buffy coat, as you can see here, it's less than 1% of total circulating blood. So first of all, you're dealing with a very small fraction of cells in the circulating bloodstream. And of those peripheral blood mononuclear cells, this is how it breaks out for lymphocytes, monocytes, and dendritic cells. So now you can see, okay, of that less than 1%, you don't have too much population of these cells here. Sympathy goes out to Dendrion, who's collecting dendritic cells, 1 to 2% right there. Not very much to catch. And then if you look at that even further, your lymphocyte subsets broken down here, T cells, B cells, NK cells, this gets even smaller. If we're trying to target NK cells, there's just not very much to get. So this can be very challenging. And I wanted everybody to see this photo. This is kind of the bread and butter for the apheresis operator when they're using an instrument. Now this, to be clear, this is just with a specific instrument. There are a number of different types of apheresis instruments. There's 2 dominant platforms that are used for cell collection. And this is what's called a colorgram, and this is used on the Terumo Optia instrument. And the operator uses this colorgram to guide them in their fine-tuning of directing the instrument to collect the target cell. So you can tell the instrument to load its its mononuclear cell collection software program, and it will use that software program to change the packing factor, the speed at which the centrifuge spins, to position the white cell layer specifically in front of a collect portal. That's about as fine, that's kind of the big movement of the instrument. You can't get too much specific beyond that. So what the operator can do, however, is they can look at the color of the product that's leaving the centrifuge to determine how many red cells are in that product. So a really dark red product equates to something that has probably, I'm going to go back here and show you, it's going to have more red cells in it than it's going to have a lot of leukocytes, right? So if you go back here, you'll see that the operator on a stem cell collection is looking to get a slightly darker product. So that's because those hematopoietic progenitor cells are living a little bit deeper in that buffy coat layer. So the nurse has to dig a little bit further down into the buffy coat layer, getting a little bit of a redder product, knowing that there's going to be more hematopoietic progenitor cells living closer to that red cell layer. So they're looking for this slightly darker product, and there's a product bag over there that shows you that slightly darker product. If they're looking for a mononuclear cell product that's got a T cell target in it, that's a non-mobilized collection, and that buffy coat layer is going to be very, very thin, razor thin. So when I showed you that picture of that viewport that the operator is looking at, all you could really see was a bunch of plasma and a bunch of red cells, and visibly you couldn't see any kind of buffy coat layer in between there. If you have a mobilized product, you can see a buffy coat layer. It's thicker. There's a lot more cells there to grab. But for these non-mobilized products where you're just getting whatever T cells are floating in the peripheral bloodstream, there's not much layer to work with. So the operator is going to have to be struggling to fine-tune the instrument to get right into that razor-thin layer. And what they're knowing is those lymphocytes, monocytes, they're going to be a little higher up in the buffy coat layer, further away from the red cells. So they're looking for a lighter product here. And you can see there's a very subtle difference between the color of these two products. But that's about the limit of the flexibility that the operator has in trying to fine-tune this instrument to get a T-cell product. So clinical trial operations at SCCA are complex, just like they are anywhere else. I just kind of did a brief throw stuff on the wall here of what our operations look like. And as I mentioned before, this is an apheresis-centric view, but if Karen were up here right now, she would put immunotherapy right in the middle of there, but it would all be the same players. So this isn't to show any hierarchy or to show that anybody's a central player. It's just to show that these are all the folks swimming in the same ocean to get the same product out. And on the left here, this shows you how the linear progression of clinical trials here at Seattle Cancer Care Alliance. I'm not going to get deep into this. This is not tremendously unique. It's just how we butter our bread here. In apheresis, the operations that we have to be paying attention to quite frequently are: where are we going to be performing this procedure? What are the documents that we need, the order sets that are required to do the collection? What equipment will we be using? What personnel are required for the procedure? What's the billing going to be? These are just some of the aspects that we have to be paying attention to. Now, with a marketed product, you have that same level of complexity, and then you're going to add on just a little bit more complexity on top of that to make it fun. So with a marketed product, now you're going to have an account manager that you're going to be working with. You're going to have an apheresis operations department that's going to be sending you the coordination for scheduling and for the product pickup and shipment. You're going to be dealing with their quality department for the audits. And you're going to have your relationship with the courier who might be picking up that product for shipment. So getting started, this is a little bit of the logistical areas that you need to pay attention to. So there's always going to be a pre-study visit and a site initiation visit with a clinical trial and a marketed product. And at these visits, including audits, this is where they're going to uncover gaps in your current operations, and they're going to clarify preparatory tasks for you. So I would caution anybody going through this process to be prepared to revise your current operations. You may think everything's working just fine for you, and it probably is, but to coordinate and get a product out for this particular PI for their trial or for this marketed product, you may have to significantly change some of your operations, or at the very least, revise some of your documentation. And they will also point out to you gaps in your processes that you may not know existed before. This is not necessarily a bad thing, but it's certainly a headache moment. Then there's going to be a point for protocol or collection manual review. Medical directors and apheresis collection staff should be looking at these very closely. If you don't have those people looking at your protocol or the collection manual coming through, there's going to be significant problems downstream. So we always have one of our nurse specialists looking at the protocols that are coming through, and we have our medical directors review it as well to make sure that the request, the ask from the trial is appropriate for us to deliver for them. We also needed to pay attention to pricing and billing. Is this going to be standard of care as part of the clinical trial, or is this actually going to be a non-standard apheresis therapy as part of the trial? And I would just, as a piece of advice, anybody who is embarking on the immunotherapy adventure, that they should consider an implementation fee for any work that they may have to go into for getting a trial off the ground. This is not an insignificant amount of time that your staff will devote to getting a trial up off the ground. When I say not insignificant, I could mean weeks, months, close to a year of not sustained, but certainly constant effort by multiple people in your department doing document revision, doing logistics planning. This is a lot of time and people resources that you'll be committing to this. Order set creation is something that could be a problem for you or may not be a problem for you at all, depending upon what your platform is. Are you all paper? Are you paper and digital? Are you digital only? These are certainly things to pay attention to because the orders will be different. The requests will be different for every clinical trial coming through. And training. This is one of the larger challenges that you'll run into for any clinical trial or marketed product coming through. We have 16 nurses in our apheresis unit. That's on the larger side of an apheresis unit. Smaller units tend to be more like 3 and 4 nurses. It's hard to get that many people trained up to speed on all the details of a variety of trials that are coming through your unit and a variety of marketed products that are coming through your unit as well. So you have to be cautious about what's that model going to be up front. Does the sponsor do the training? Does the manufacturer do the training? Are you going to have a train-the-trainer model? Will you train just a small subset of your staff initially and then have them train everybody else? Will the sponsor allow for that? Some sponsors don't allow for the train-the-trainer model. These are important things to pay attention to. And then you have to ensure that your trained staff are available. I've got one of my rock stars here in the audience, and when we were lifting one of our marketed products off the ground, we had to make sure that her day off was not the day that we were collecting that clinical product, because that marketed product, because she was the one with all the specific knowledge, and we were having her be the super user initially. So this requires, again, logistics planning to determine which staff are going to be available for your procedures. More for logistics planning, what days and times will be used for the collection. You might think you have your preference for which days and times you're going to use, but then the clinical trial, they have a completely different idea of what this is. So I'm just going to share with you the conversation. So we'll need that product Monday, Tuesday, and Wednesday, and those are the only days you can collect. And then what I say is, we're going to collect Monday through Friday, and you're going to get the product when you get the product, because we have significant barriers that we can't always bend on. The manufacturers right now are up against a significant challenge, and I'm not unsympathetic to this. They're having a hard time scaling up, right? This is the frontier. Everybody's new on this, right? So they don't have a lot of capacity yet at their plants, and maybe some of them have a ton of capacity, but they don't have all the operations nailed down. So they're trying to tell you, please, can you only give products to us on Monday, Tuesday, and Wednesday? Well, that might be fine for a small clinical site that has small operations. We are doing probably 15 procedures a day. we're servicing 3 different clinical sites. We do autologous, allogeneic collections. We do a lot of therapeutic apheresis. We have significant operations. We're doing probably about 3,500 procedures a year. So this is a challenge for us when somebody says, you're going to do collections on this day. So this is going to be a big point of negotiation, or you're not going to negotiate, whichever works for you. Also important to know what's going to be the length of that collection. Every protocol, again, is going to have variations on how much volume of blood is going to be processed from the patient to grab these cells. So that collection could be a 7-liter collection, meaning we're going to process 7 liters of your blood volume through the instrument, which is going to be a shorter period of time than a 15-liter collection. And also changes in what type of anticoagulant that's mixed with the blood in the machine, that will also determine the length of time for the procedure. So this makes a big difference in determining, yet again, which days, which times. Often the manufacturer says these can only be done in the morning. Yeah, no, that's not working for us. You're going to get it in the afternoon as well. So a lot of pushback is going to happen with this, and I know Dave Maloney is tired of hearing me say, you've got to find a way to store these products overnight. So the more flexibility the manufacturer has, that's the better option for the apheresis unit for their operations. If they can allow us to collect products in the morning and collect products in the afternoon, Monday through Friday, that's the best case scenario for all of us. Logistics planning for lab results that need to be drawn. I know many of the SCCA folks in this room here probably consider CD3 a bad word. This was very challenging for us to determine when a CD3 will be tested on the patient prior to collection in order for us to determine how much blood volume will be processed. Also, the patient's absolute lymphocyte count sometimes needs to be known for some protocols in order to know what to collect. So these are logistics that you may not have had in place prior to any of your operations with this clinical trial coming through, and now you have to figure out how are we going to do this additional testing that's non-standard for us. Orders and volume processing calculation. This is something that's unique to many different protocols. So some protocols just say, collect for X period of time. Some protocols say, process 7 liters, process 12 liters, process 15 liters. Doesn't matter who it is. It's you or it's a linebacker, that's how much you process. Then other protocols are very specific. Based upon that patient's CD3 count, you're going to make a specific determination of how much blood volume to process. Well, who makes that determination? Is the nurse making that determination? Is it a physician? Is it a nurse practitioner? Is it a PA? When do they make that calculation? The night before, the day of? These are big questions that you have to figure out logistically before you get off the ground. And then packaging and shipping. So where does this product go once it's done in the apheresis unit, and how does it get there? Each trial has a different way of handling that product going out the door. Your nursing staff in the apheresis unit, they're going to say, yes, so I didn't go to nursing school to learn how to put something in a styrofoam box. So you can get a little bit of pushback on that occasionally. And as the operations manager, you need to figure out, are we using people to their license and to the best of their capabilities and efficiently? So it's going to be important to know who's going to do that shipping and packaging. Also, where are those supplies going to be kept? There's limited acreage for your operations. These shipping containers aren't tiny, so who's going to have a closet to put those in? Who's going to manage those supplies and that inventory? So collection optimization is a big buzzword that's going on right now with sponsors, manufacturers, because of course everybody wants to get the best product they can possibly get, of course. And as I mentioned before, the instrument is smart enough to separate out the blood into its different subsets, but it's not so bright that it can say, I am just going to get you a T cell today, or I am just going to get that CD3 cell that you're looking for. So what can the apheresis unit do to optimize this collection given the lack of flexibility that we're going to have with the instrumentation? So the things that we're looking for are uninterrupted blood flow. We're going to be looking for blood flow that's going to be somewhere between 80 to 100 mLs per minute. So the apheresis team is going to be making recommendations to the providing team on what vascular access should be used. Ideally, you want to use peripheral access because that's going to be the least invasive, but they may not have peripheral vasculature after having been beat up with tons of chemotherapy over the years. So they may have to have a central line, then that central line has to be compatible with high flow. They may have to have that line put in the night before, the morning of. How does that impact operations? So that's a challenge there. Uninterrupted blood flow, however, leads to the cleanest product that you could get on that instrument. So if you have constant stop and start in blood flow because the vein won't allow the blood to come out consistently or the catheter isn't working very well, you're going to get a lot of contamination of other cells coming into your product. Every time the machine stops its flow, it's like when you lose your place reading a book. You have to go back and read again that chapter before or that paragraph before. So the machine's doing the same thing. It's going to spill a little bit of red cells into that product or spill a little bit of platelets into that product. So we want to keep uninterrupted blood flow as much as possible. We want to use a slower flow rate. That's another thing that we can try to do to optimize the cell collection to get just what we're looking for. Slowest is best, but sometimes your nursing staff wants to push things as fast as they can because they know they have another procedure afterwards, they've got a lunch break, they're tired, but oftentimes the slower we go, that's the better thing to get a cleaner product. Custom volume processing is something that's starting to get a little bit more common. As I mentioned before, sometimes it's just a standard black box, you process 15 liters. But now it's becoming a little bit more common for the manufacturer to customize how much volume is processed based upon how many cells that patient has. So that's another thing that theoretically could get the manufacturer the right cell dose that they're requiring. And then the other thing that will help with collection optimization is getting feedback from the manufacturer. And this is a challenge, I have to admit. What often happens is the apheresis site will collect the product, they send it off, and we never hear anything again. So we have no idea if any of the optimization techniques that we're trying so hard to employ are having any impact on the product. We have been exceptionally fortunate at SCCA that our PIs have been geniuses enough to figure out a manufacturing process that has yet to fail with our cell collection. So we could essentially have a patient coming in the door with one white blood cell, and Dave Maloney always says, go for it, do it, put that patient on the machine, and they manage to get a product out of it. Now, that's great. They found the right formula for that, but there's definitely going to be manufacturing processes that are less tolerant and less flexible than that. And that's a challenge that the manufacturer is up against. The apheresis site can do a little bit to help them out with that, but if we don't hear from them what their challenges are, there's nothing we can do to help them out with that. So these are considerations that we like to teach the manufacturers about and that we're also paying attention to throughout the procedure. From the patient's perspective, what we're looking at is low lymphocyte counts. Most of these patients, again, have been pretty beat up and or they're recovering from a dose of chemotherapy recently, so they may not have a very high lymphocyte count, and that could be a big challenge for manufacturing. Their cells may not be very healthy either, so even though you're getting a lot of cells, they may not be very robust. That patient's going to have a lot of comorbidities, which is going to make collection always a little bit challenging. So the sicker your patient is, the more challenging the procedure often can be with interruptions in cell collection and the blood flow. The patients may often need blood product support, which is something that manufacturers, they don't really understand about that. So we'll get calls to say, well, so now, hang on a second. You gave them platelets just before that procedure, so are those platelets going to go get into the product? Or you gave them some red blood cells the night before, how is that going to impact the product? Well, it's not going to impact the product. It's going to be okay. Everybody calm down. But they don't know that, so this is something that manufacturers just need to have some understanding of. And then what's the emotional state of that patient walking in the door? Oftentimes, this immunotherapy product is the last stop for this patient. So they can be very jittery, and some of them are very excited, but usually folks are very tense when they're walking in the door for these procedures. Other considerations that we look at are manufacturer tolerances. So it's good to know what's the acceptance criteria. For clinical trials, there often isn't an acceptance criteria, but for manufacturing, for marketed products, there are acceptance criteria, and that boils down to how many cells are in that bag. And if you're not meeting that acceptance criteria, they'll probably ask for a second collection. Product specifications leads into this as well, so that we need to know what the product specs are in order to know, are we going to meet that or are we not going to meet that? And that will play into, do we run that patient? Do we run more volume on that patient? These are all important to be paying attention to. And then what is the cross-cellular contamination tolerance for that manufacturer? Oftentimes manufacturers, they will never tell you this information. We'll find out about it 6 months into the trial, and they'll say, you know, this product's really red. What have you guys done differently with your collection process? And we'll say, well, we really haven't done anything different. Have you changed your manufacturing process? Well, then we find out that they're washing the cells differently, or there's something different on how they're doing their manufacturing. So again, important to know, is it bad for them to have more red cells in the product? Can they tolerate more red cells? Or is it okay if they have more platelets? Important for us to know how much leeway we have when we're collecting that product for them. And then manufacturer requirements there's so much variety, from how much blood volume to process to the circuit anticoagulant that they'll allow you to use. The standard is anticoagulant citrate dextrose, but oftentimes, as we do at SCCA, we add heparin to that. A lot of manufacturers can't tolerate heparin in their manufacturing process, so they'll say, no, you can't use that. That changes how long the collection is. Product additives, some of them will specify add plasma, don't add plasma, add anticoagulant, don't add anticoagulant. So that's always a little bit different. And then they all have a variety of ways to take the bag off the instrument. You should leave a 12-inch tail. No, leave a 6-inch tail. Don't cut here. You should snip there. All these variations are important for the apheresis site to know. So to help out our staff, we use a job aid to help them remember all this stuff. So I just want to caution everybody that immunotherapy and apheresis for immunotherapy is not for the weak, or it's certainly not for the timid. To call them a boutique protocol is the truth. Every single protocol has just something a little bit different than the other one that you did. So we use, at our site, job aids. We call them a process guideline that acts as a recipe to tell the nurse operator how to do that collection for that specific protocol or that marketed product. And you can see that we get exceptionally detailed on this. I hear a lot of chatter from the nursing staff about how much they fear or dislike doing research collections because of all this variety and detail that's involved with them. This is significantly more detail than any of our standard collections. So we have to be very helpful in providing all this detail. This gets detailed down to, what do you do with a copy of this document? Who do you give it to? Who do you call? What do you add to the product? Who's picking up the product? Who's shipping the product? What's the phone number for the study coordinator? All this detail, if you don't follow this detail, which we're distilling from the protocol or the collection manual, then that's going to lead to a protocol deviation. And so we have to be really cautious about making sure we're following all this correctly. I would say, however, that the risk of using something like that is version control. Marketed product sponsors are often a little wary if they see something like this, because they'll say, well, how do you know, or how do we know as the sponsor that you're using current information? So we have robust version control with this document, making sure that we're feeding the information into this document from the current collection manual. Documentation and reporting is not insignificant. There's a number of different methods that clinical trials or protocol sponsors specifically marketed product companies will be using. Some of them will use paper documentation, which is okay, but legibility is a risk. I just got a message this morning that we had a legibility challenge on one of our paper documents that we submitted for a clinical trial. And also, paper can get lost, so it gets shuffled in with other papers, so that's a challenge using paper documentation. Electronic documentation is more common with the marketed products, but not all of them are using it yet. It's great for legibility, you don't have that challenge, but accessibility can be challenging. So if documents are sent to the collection site, they may only be being sent to one person, and then of course that person's going to be out on vacation, or they're going to be sick, or helping out their aunt, or whatever. So you got to figure out, there's got to be multiple recipients and redundancy in that system to make sure you've got the documentation available. And then what's becoming more common are web portals, and it's still being used now. This is good because, again, it removes the risk of legibility and it increases access, but the big challenge with web portals is training all your staff to them. They're all different. They're all a little bit challenging. It requires more than one person to do verification steps in the web portal, so you have to have a few people on hand, and then you have to train all your staff to use it. So this always leads inevitably to documentation fatigue and coordination and confusion with all these different protocols. So it's not an insignificant challenge. Labeling is always a fun challenge. Each protocol or trial or marketed product is going to have a different requirement for labeling. You might have your standard process, and then they're going to tell you, well, we can't do that. So you should take this label and you should staple it to this piece of cardboard, and then you should put that on a tie tag. Or you can still use your label, but it can only go down here in this bottom quadrant of the bag, and it can't touch our label over here. Okay, so lots of different variety and requests from the sponsor about how you can put your labeling on, but my recommendation is to stick to your guns, adhere to the FDA and the FACT guidelines and ISBT labeling requirements that are in place for products, and stick to your guns about what needs to be in that product, and force the sponsor or the manufacturer to work around you, because the last thing you want is a citation for doing it the wrong way, and then let the sponsor or the manufacturer figure out something else. Packaging and shipping, just a variety of all the different ways you can put a bag of cells and ship it across the country or across the street. So these are just different pictures of different packaging devices, but important to ask the questions: who's going to package it up? Is that going to be your apheresis staff, a study coordinator? Is that going to be the cell therapy lab? Consider the space. Where are you going to store it? How long does it take to package it up? Is it complicated? Do you need training? All things to pay attention to. And then ongoing operations, it doesn't end with just that first site implementation visit. So there's going to be surveillance audits, which could be a full day or 2 days. So you should always insist on notification. Make sure you know who's showing up at your site. These should not be surprise visits. Who needs to be available for these? What documents do you need to have available? They're often going to be looking at all of your cleaning records, your training records for your staff, your policies and procedures. We have binders ready to go for these audits. And then collection manual revision will happen. It could happen twice a year, more than that, or less than that. So collection manual revision, you need to make sure you've got version control for that, for electronic and paper documentation that you've created from any of the collection manuals that you're using. And you also may need time to change your operations to meet these revisions. So that's another thing to consider, that you may not get notification very far in advance of a change that they're making to their collection manual, and they're gonna say, this is gonna be implemented next week, and you're, well, hang on a second, I got a lot of stuff to do. So oftentimes you're gonna have to push back and say, we will comply, but we need 4 weeks to do this. And usually you can negotiate that with the site. And then, of course, there's going to be more training every time they change the collection manual. So that's something that our staff have to always be going through. I want to give a huge shout out to our team, our apheresis team, who can't all be here today. We've got one of them here. They are absolutely fantastic and so patient and tolerant most of the time. And when they're not, I totally sympathize with them. It is exceptionally challenging to pull off these trials. And we're hiring. And I've got some business cards with a phone number on it. So come find me.